title of mine was suggested to me by Sue and by Jenny Hall for a blog that I wrote. And this question of where are we going and how will we get there is a classic question that people who are leading services, maternity services, public services, trained services, need to ask when they're starting some kind of change. Where are we going? It's a simple, classic question, but really useful. But it's also useful for any of you at any stage of your life. If you're thinking about your practice, where are we going? And this question of where are we going is related to purpose. And today I know the challenges that all of us have experienced, but I want to suggest to you that this re-questioning of purpose is absolutely critical given the stage that we're in the maternity service. And we are at a fork in the road. We felt as if we were moving forward safely with better births, rolling out continuity of care. And then the pandemic came along. And it's being suggested that we go off in other directions. And I'm going to be suggesting to you today that actually we stay on the main road. We don't turn back and we don't fork off. So this understanding of what our purpose is absolutely vital to the beginning of any change, managing and leading and individual practice. How will we get there is related to culture, policy, organization, systems, and process. And today I want to recognize our challenges, but say that we might only resolve these if we have the appropriate resources, of course, but by transformational change. We can't go back, however tempting it might be. We can't stand still, and we must move forward. The world has changed, isn't it? I did this slide before the invasion of Ukraine. Terrible for the people in Ukraine, but it will affect everybody in the world. But we've had the pandemic, and we've had the Panorama program showing the grief of many families in a particular service in England. And we've got a press and a media that regularly vilifies midwives and denigrates the science behind normal birth. So in this crisis, this midwifery crisis, where many of you are working with too few resources, with services that are at capacity and you feel at capacity, we also need to safeguard quality and this transformational program that we're starting in England and Scotland and Wales and Northern Ireland. We need to move forward. We need transformative, fundamental change. We need a change to culture, systems, structure, and relationship-based care. So where are we now? I've talked about the impact of the pandemic, the midwifery crisis, and it isn't just about poor resources. This is about deep-rooted problems that have to be resolved. And we won't resolve them just by adding more resources. We will all be involved in a transformational change, either of our own individual practice, or of whole services, or of education or activism. We saw the grief on the Panorama program, and I actually couldn't watch it late at night. I knew it would keep me awake. So I actually played back and watched it during the day. And it was terrible to watch the grief of those parents. But what struck me was, because that grief is so profound and the sense of injustice, we must make sure that the way we respond to the Ockenden report, which is coming out on March the 22nd must be effective. We must do the right things to make sure that there's change. And we also need higher standards of reporting in the media and in the newspapers. And actually, I have to say that the media reporting has reached new lows, in my view. I know, though, that it must feel impossible for you, for all of us, but actually it's not. We have a way of moving forward. Last November, I met midwives at the Association of Radical Midwives meeting. I met student midwives and qualified midwives and other birth workers. And the voice of the student midwives was so compelling. At every session, they stood up and said, "But we've never seen a physiological birth. We hardly ever look after a woman without an epidural." They're aware of the importance of the physiology, that actually the physiology of pregnancy, labor, birth, and the early weeks after birth and breastfeeding prime the mother for mothering. They help in the health and well-being of the baby. They reduce pain. They give a sense of social openness. Oxytocin is the hormone of calm and connection. They know that science, but they actually can't put it into practice in the clinical areas. So we have a whole area of our science, which is at the foundation of midwifery, that is called a cult, that's called an ideology. And our work actually will be to put forward that science so that it's understood both the scientific basis and the importance to good care. And then I went to the Midwives March in Bond Square in Oxford. We had a huge gathering. It was organized by a wonderful community midwife, Trudy Brock. And she had asked me if I would say a few words. And when we got there, it was a cold, windy, grey day. We were really worried that nobody would turn up. When we arrived, the square was absolutely full of people with banners, of midwives, of the parents of midwives, of mothers, fathers, babies. And actually, I met one of the babies that I had been midwife to many years before with his own children in the square. And it was the most amazing event because we had gone with a megaphone. And I stood at the top of Bond Square and there was a busker who was singing very, very loud. And I said to him, "Would you mind turning down your singing, your music while we're talking?" And he said, "Would you like to use my microphone?" And I spoke, and one by one, midwives, student midwives, the parents of student midwives, parents stood up to speak. And we went way beyond the time that we thought we were going to finish. And what struck me was that the midwives were the people talking about how they felt they had to keep saying sorry to the women that they were looking after. They were sorry because the induction of labor that was, they understood, life-saving had been delayed by hours and by days. It was the parents of those midwives who said their children weren't having anything to eat or drink during the shifts. Basically, the message was midwives wanted to give their best and they needed a situation in which they could do it. So, amidst all of this fear, loss, great uncertainty, pressure of responsibility that surround us in this crisis, all the turmoil, how might we preserve good practice at the moment but continue the progress that's been made? And I think the first thing that we have to think about is heart. It's compassion and empathy. Compassion and empathy for parents who've experienced poor care, who've experienced mental health problems because of the care that they've had, because of poor outcomes. But it's also empathy and compassion for the midwives, the doctors, the maternity support workers, the doulas, everybody working in the maternity services. Many of those staff are suffering moral distress and burnout, and we need to recognize that. Sometimes the situation feels absolutely impossible, but we also need wisdom. We need heart and we need head. We need to plan and consider the fundamental changes to be made, and we need to use the extensive knowledge available to us. We need to gain confidence from the many examples of successful leadership and establishment of transformative change despite current difficulties. And one of the things that I would like to plug is that it's as important to learn about poor care and services that are failing, the lessons from that. But we must similarly learn from good services and where practice is good and where there's success, and there's much of it about. And we also need courage to recognize the reality of the challenges we face, the deep-rooted problems that need radical change of culture, structure, systems of care, and overhaul of the evidence that's used as a basis for our practice and organizations. We need courage to speak up on topics that have been rendered unspeakable and about the way problems have been intensified. We can't turn back. We can't go back to the days where we aimed for antenatal, postnatal continuity, where we aimed to get one-to-one care in labour without actually developing continuity of care around the whole service, because it doesn't work. We need fundamental change in order to make the services that we're working in sustainable. Many present-day services aren't fit for purpose, and services don't work for those who want or need interventions. Neither do they work for those who need and want physiological birth. Sue Down calls it a classic lose-lose situation. Risk has become diagnosis. Our cesarean section rate is the highest ever, over 31%. Induction of labour rates are increasing. Now 1 in 3 women have an induction of labour, and Birthright says only 1 in 4 felt they were properly prepared. Access to pathways that will offer normal physiological birth with effective support is limited. Vaginal birth is conflated with normal birth, and that is really important, because when we hear about percentages of normal birth, often included in that are women who've had induction labour, epidural, and so on. Why is that important? It's important because those interventions, while they are often needed, but if they aren't needed, they actually disturb the physiological processes that help women manage labour, that help women go into labour, that help women with the pain of labour, with the relaxation that's required, with this kind of social openness, with the calm and connection, and also in their transformation to mother, the physiology that helps the woman know that she would fight like a lion for the life of her baby. So when we conflate vaginal birth with normal birth, it is hugely, I think it's hugely mistaken. It's made services impossibly complicated. If you think about the rate of vaginal birth and cesarean birth actually imposed on our already complicated services, it makes life much more difficult. So we need to follow the evidence and optimize cesarean section and optimize normal birth. And that word optimize is really important, because what it means is that we make sure that those women who need a cesarean section, who need and want a cesarean section, have access to a cesarean section. But those women who don't need it actually have access to the support for normal birth. And the term optimize is hardly ever used. It's not a particularly user-friendly word, but it's a really useful one. So I've said that we're in this fork in the road, and the direction we take will affect all of our futures. So we have to transcend. We've got to build on the progress that we've made already through Better Births and Best Start in Scotland. We need to transform maternity services, and we need to change the conversation. And a lot of my work over the last 30 years or so has been in humanizing birth. And just briefly, I talk about humanizing birth, not humanization of birth. Humanizing birth actually recognizes that birth is transformative for the mother, for the baby, for the partner, and for the family. And that transformative process, a positive transformative process, needs to be supported for all of us. And it starts with the basic question: how might we realize the promise of childbirth, the potential of new life, and make safe, humanized childbirth a sustainable reality for every childbearing woman and her baby, every parent, every family, no matter what their circumstances and where they live? This takes us away from the polemics. It takes us away from this division between normal birth and intervention. And it lands on the individual needs of every woman, every baby, every parent, every family. And we need to be able to have open, respectful, honest conversations without our discussions and our language being censored. The term normal birth has been censored. It's very difficult to use it. Should we use a different word? I think the question is, how will we preserve access to straightforward, well-supported, confident birth for those women who should be on that pathway? We've got the building blocks, we've got better births, we've got maternity transformation. All for Maternity have been commissioned to deliver sessions on well-being and leadership through the NHS. It's a pilot, but it's very promising for the future. And midwifery continuity of care is a mainstay, with one of the most comprehensive implementation plans I've ever seen, with strong, engaged leadership. Jackie Dunkley-Bent has led that. Trixie McCarry is a wonderful hands-on leader who's available to anyone who needs help in moving it forward. And watching Panorama the other day, and the distress and the grief and the poor outcomes of those parents, I was struck by how important this relationship-based continuity of care is, and it certainly needs to be moved forward if we're going to respond to these crises in maternity services. We need to learn the lessons where care fails, but also learn from positive examples, positive stories, and analyze why success works. One of the things I think that helps in a crisis is to remember how vital our work is to individuals, to families and communities. And it's always helped me. I have to tell you that 2 weeks ago, it was 60 years since I started as a student nurse in London, in Hammersmith Hospital. And I've been a midwife for very, very many years. And believe me, there have been times that I've thought, I have to give up, it's too hard. And then I'll meet a midwife that things have worked for. I'll meet a woman who's had good care, and it keeps me going. So what we're talking about is fulfilling the promise of birth, this promise of happiness, of joy, of new life, and even of ecstasy. But we have to recognize that where things have gone wrong, we need compassion. Fulfilling the promise of birth means supporting strong bonds of love for the whole of life and into the next generations for everybody. And I've just read a wonderful blog by Joanne Crawford, head of midwifery in an NHS England trust, who said that when she practiced as an E and F grade midwife, she held the well-being, confidence, and happiness of the women and their families at the center of everything she did. Our aim should be for all midwives to be able to do this, and I'll give you the reference to that blog in a moment. So here is my blog, which, if you haven't read before, will actually coordinate with this lecture. And I think you're going to get copies of the slides. So, and then other links, including the Lancet series on optimizing cesarean section, the NHS guidance on moving forward on continuity of carer, Joanne Crawford's blog are all there. So I want to finish with some sense of the transcendence of what you're involved in, the importance of being a midwife or other people who are involved in the maternity services, the real impact it will make on people's lives, not just for this generation, but the next generation, for better or for worse. I want to celebrate midwifery and midwives, our achievement and our success. And I have to say, I love being a midwife. I love calling myself a midwife, and I love other midwives. As a president, I went round seeing so much good work that was really heart-stirring. And of course, a strong scientific basis. So in Iceland, where I visited and I've worked with the team from Iceland for many, many years, I just got an honorary doctorate from the University of Iceland. The term midwife means mother of light. It also means with woman or sitting over the woman. And you'll see the Icelandic, if any of you can read Icelandic, on the top of this slide. Ólöf Asta Ólafsdóttir, in her PhD thesis, talks about ways of knowing. The hidden knowledge of midwives comes to light. She talks about the new enlightenments of knowledge that midwives bring. We might see this enlightenment as bringing the perspectives of midwifery out of the shadows, from theory and evidence that is often still seen as contentious, into the light of recognition and mainstream practice. This is vitally important to the modern world. Over the last 2 decades, the growth of knowledge, changes in practice, including the development of midwife-led care and continuity of carer, using evidence in practice and policy, understanding the experience of women and their families, has been exponential. We know that educated, skilled, compassionate midwives have the potential not only to save lives, but to give the best start in life for women, their babies and families, and to a healthy, happy society in every part of the world. One of the central questions facing us is, how do we enable midwives and midwifery to realize this potential? The existential crisis that we face around the world, from COVID and now the invasion of Ukraine, is also a crisis of meaning. I want to remind you of the profound meaning your work has, being with women as they bring their babies into the world, supporting them and their partners and families at this stage of life, when a human being has come into existence. I really hope that we can learn the lessons of tragedies and heartbreak that we've seen and heard about. But I also want to shine a light forward so we can learn from and build the best. Your work makes a difference to lives, to our future, and I really honor and respect you for it. Thank you all very much for listening.